Welcome back to the deep dive. Today, we're really digging into something fundamental, the procedural safety rules for giving medications.
Absolutely. We're taking all those detailed steps from pharmacology and the nursing process, Chapter 9, and boiling them down.
The goal here is clear, actionable knowledge. Think of it as building your safety blueprint for clinical practice.
Exactly. This isn't just theory, it's about preventing errors, ensuring that what's prescribed actually helps the patient safely. It's foundational.
And the cornerstone for all of this really has to be the 9 rights of medication administration. We all know the first 5 pretty well, right?
Right. Drug, dose, time, route, patient, they're ingrained.
But those last 4 are just as vital. Right documentation, right reason, right response, and maybe the most fundamental interaction, the patient's right to refuse.
You can't forget those. They complete the safety picture.
Okay, let's start right at the very beginning before you even touch the medication. Hand hygiene.
Seems basic, but there's nuance. Alcohol rubs are usually the go-to.
Usually, yes. But the big exception the source highlights is Clostridioides difficile, C. diff.
Ah, yes. For C. diff, alcohol won't cut it. Those spores need friction, soap, and water to be removed effectively.
Good point. Then comes what I think of as the core defense, the rule of 3 checks.
This is non-negotiable. It's a built-in redundancy check. First, check the drug label against the order, the MR or EMR.
First check.
Then check it again right before you open the package or prepare the dose.
Second check.
And finally, one last check immediately before you actually give it to the patient.
Third check. It's like a triple lock system.
Precisely. And for certain medications, that lock needs reinforcing, high-alert drugs.
And the text specifically calls out insulin and IV heparin. What's the rule there?
For those 2, mandatory verification by 2 licensed nurses before administration. The risk of significant harm from an error is just too high.
So that second pair of eyes is crucial.
Absolutely. And speaking of verification, the right patient rule always requires checking 2 distinct identifiers.
Usually name and date of birth, right?
That's the most common. Or maybe name and medical record number or account number. Depends on the facility.
Barcode scanning is common now too, which helps.
It does help, but it doesn't replace the human check. And the bottom line, the absolute final safety net, is you. If you're unsure about anything, the drug, the dose, the calculation, even the expiry date, you stop.
You stop the process, never proceed if you're uncertain.
Never guess. It's just not worth the risk.
Okay, so that brings us to the patient themselves, their role, their rights.
Yes, patient autonomy. Before you give any medication, you need to explain clearly what it is, why they're getting it, how it works, and what side effects they might experience.
They have to be informed.
They have to be. And they have the right to refuse, if they do refuse.
Document it immediately.
Yeah.
And clearly state the reason they gave, if they gave one.
Exactly. And then there's the disposal protocol. If the package is unopened, usually it can go back to the pharmacy or the automated dispenser.
But what if you've already opened it, especially a scheduled drug?
Well, if it's open or partially prepared and it's a scheduled substance, you can't just toss it. It needs to be discarded according to very strict facility protocol, and critically, that disposal must be witnessed.
Witnessed by another licensed professional, usually, for accountability.
Correct. It ensures proper handling and prevents diversion.
All right, let's move on to actually giving meds, starting with the most common route, enteral, meaning via the GI tract. Oral meds first.
Before you even think about popping that pill into a cup, there are key assessments. Beyond just checking the ID and allergies, of course.
Right. You need to check vitals relevant to the drug, like listening to the apical pulse for 1 full minute before giving digitalis.
Or checking blood pressure before antihypertensive. It links the drug's action to the patient's current state.
And positioning matters too, doesn't it? To prevent aspiration.
Definitely. Sitting up or side lying if they can't sit up, it makes swallowing safer, especially for patients who might have difficulty.
Okay, now for a really big potential pitfall. Crushing medications. The crushing caution, as the text puts it.
Oh, this is huge. So many errors happen here. The rule is absolute. You cannot crush, break, or chew capsules, anything enteric-coated, or drugs labeled SR, ER, XR, sustained or extended release.
Why not? Seems like it would just make it easier to swallow.
It might seem that way, but you're destroying the technology designed to release the drug slowly over time. Crushing it means the entire dose gets dumped into the system at once.
Which could cause irritation, or the stomach acid might destroy the drug.
Or worse, you could cause a toxic overdose because the blood levels spike way too high, way too fast.
So never crush unless explicitly told you can for that specific formulation.
Got it. What about liquids?
Precision is key. When pouring from a bottle, hold it so the label is against your palm.
Oh, right, so if it drips, it doesn't smudge the label. Smart.
Exactly. And measure at eye level, reading from the bottom of the meniscus, that little curve in the liquid.
And for really small doses, less than 5 ml.
Critical points.
Okay.
Use a calibrated oral syringe. Never, ever use a hypodermic needle syringe for oral liquids. That's just asking for a dosing error. Good tip. Any specific advice for kids? Pediatrics.
Yeah, a couple of key things. Don't mix meds with essential foods the child needs, like formula or milk.
Because if they refuse the taste,
They might refuse that essential food later. An aversion. If you have to mix it, use a tiny bit of something non-essential and usually sweet, like applesauce or jelly.
makes sense. And for infants,
Super important safety note. If an infant is crying vigorously, wait. Don't try to force medication into a crying baby.
why is that?
High risk of aspiration. Wait until they're calm.
Okay. What about those other enteral routes? Sublingual and buccal.
Ah, those are interesting. They bypass the GI tract, absorbing directly into the bloodstream, under the tongue, or in the cheek. Much faster onset for some drugs.
So the instruction for the patient is crucial here.
Absolutely. They
Yeah.
must not swallow their saliva or drink anything until that tablet is completely dissolved. Otherwise, it just gets washed down into the stomach and you lose that rapid absorption benefit.
And orally disintegrating meds, ODMs, they seem similar.
Similar concept, even faster. They dissolve right on the tongue, usually in less than a minute, no water needed. Faster onset than even standard swallowed tablets.
Anti-handling precautions.
They're fragile. Don't push them through the foil blister pack. You have to peel the backing off. And the rule is strict. No chewing, no swallowing, and no fluids for 5 minutes before or 5 minutes after taking it.
Got it. Now let's talk about tubes. Nasogastric or gastrostomy tubes.
Okay, first thing is positioning again. Head of the bed, elevated semi-fowlers, or fowlers. And keep it elevated for at least 30 minutes after giving the meds.
Prevents reflux and aspiration.
Exactly, and you absolutely must check for compatibility with tube feedings. Some drugs just don't mix.
Like phenytoin.
Phenytoin is a classic example. Also carbidopa-levodopa. If there's an incompatibility, you have to stop the feeding for a specific period before and after giving the drug. You need to know the protocol.
In the actual process of giving meds via tube, it seems complex.
It requires meticulous technique. Crush tablets one at a time. Dilute each crushed med separately in about 15 to 30 milliliters of warm water, not cold,
Separately. Why?
to prevent any potential drug interactions or clumping before it even gets to the patient. Then you flush the tube.
How much flushing?
The standard is 30 milliliters of warm water before the first dose and after the last dose.
Yeah.
And here's the key detail. Flush with 10 milliliters of warm water between each different medication.
10 milliliters between each one.
Okay.
To clear the tube.
Right. Ensures each dose is delivered fully and separately. And always use gravity flow. Don't force it with the plunger.
Why not force it?
You could potentially damage the stomach lining or the tube itself. Let gravity do the work. Okay, moving into parenteral routes. Injections, IVs. This is definitely a high-risk area. Let's start with needles and syringes.
The gauge system always trips people up initially.
Right, just remember it's inverse. A bigger gauge number means a smaller needle diameter. So a 25 gauge needle is much thinner than, say, an 18 gauge.
Good clarification.
Yeah.
And the #1 safety rule with used needles.
Oh, this is absolute. Never recap a used needle, ever.
Straight into the sharps container, no exception.
Well, the text mentions one specific exception, recapping an unused needle that's fixed to a syringe, like maybe an insulin syringe before use. And even then, only using the one-handed scoop method. But used needles, never.
Got it. What about drawing up meds? Ampules versus vials.
Different techniques needed. For a glass ampule, after you snap the top, you must use a sterile filter needle to draw up the medication.
Why the filter needle?
To catch any microscopic glass shards that might have fallen in when you broke the ampule. But, and this is critical, you take the filter needle off and put on a regular needle for the injection. You never inject with the filter needle.
Okay. And for vials? The ones with the rubber stopper.
With vials, you need to inject air into the vial first, an amount equal to the volume of liquid you plan to withdraw.
Why inject air?
It prevents creating a vacuum inside the vial, which makes it hard to pull the liquid out and can actually affect the dose accuracy.
Makes sense. Let's talk injection sites and techniques. Intramuscular, IM.
Okay, IM injections go in at a 90-degree angle, straight into the muscle. Absorption is faster than subcutaneous, but obviously slower than IV.
How much can you inject?
Generally, the max is about 3 ml in a large, well-developed muscle. But for patients who are thin, elderly, or have less muscle mass, you'd reduce that to 2 ml or even less sometimes.
And site selection.
Ah,
This has changed, right?
big change emphasized in the text. The dorsogluteal site, the upper outer quadrant of the buttock, is no longer recommended.
Why not? It used to be common.
High risk of hitting the sciatic nerve, it's just not safe. The preferred and safest site for IM injections now, for pretty much everyone, is the ventrogluteal site.
The side of the hip area.
Yes, using specific landmarks. It avoids major nerves and blood vessels. Much safer.
Okay, and what about that special technique, the Z-track method?
Ah, Z-track. You use this specifically for medications that are known to be irritating to subcutaneous tissue, like iron dextrin is a common example.
How does it work? What's the purpose?
It's clever. You use your non-dominant hand to pull the skin and subcutaneous tissue laterally, like to the side. Then you inject the medication at 90 degrees, hold the needle in place for a full 10 seconds after injecting
10 seconds? Why so long?
to allow the medication to start dispersing within the muscle tissue, reducing the chance it'll track back up the needle path. Then you withdraw the needle smoothly, and only then do you release the skin.
Ah, so the skin slides back over the injection site.
Exactly. It creates a zigzag path, sealing the medication deep in the muscle and preventing it from leaking back out into the subcutaneous tissue where it could cause irritation or staining.
Neat technique. Okay, subcutaneous injections, SUBQ.
SUBQ goes into the loose connective tissue just under the skin. Absorption is slower here. These are typically smaller volumes, like 0.5 to 1 mLO,
Angle of injection.
usually 45 or 90 degrees, depending on the needle length and the amount of subcutaneous tissue the patient has.
Is there a specific safety rule for certain SUBQ meds?
Yes, a very important one for anticoagulants like heparin or enoxaparin. You do not aspirate, meaning pull back the plunger to check for blood, and you do not massage the site after injection.
Why no aspiration or massage for those?
Both actions increase the risk of bruising and hematoma formation at the site, which you definitely want to avoid with anticoagulants.
Makes sense. Last injection type, intradermal, ID.
ID injections are mainly for diagnostic purposes, like TB tests or allergy testing. It's the shallowest injection.
How shallow?
Very shallow. Angle is only 5 to 15 degrees, with the bevel of the needle pointing UP. You're aiming just under the epidermis.
And what should you expect to see?
You should feel some resistance as you inject, and you'll see a small bubble or bleb form right under the skin, kind of like a tiny mosquito bite. That confirms correct placement.
Okay, shifting gears now to intravenous 4-fee administration. Let's talk piggybacks, IVPB.
Right. Often these come prepared from pharmacy, but sometimes you might get an add-a-vial system.
What's the key step there?
You have to actively mix it. You need to snap the connection between the bag and the vial, squeeze fluid from the bag into the vial to dissolve the powder, mix it well, and then squeeze the dissolved drug back into the main IVPB bag. If you just hang it without mixing, the patient gets plain fluid, not the drug.
Critical step. You mentioned something called back priming. What's that about?
Back priming is a technique to reduce contamination risk and save a bit of fluid. When you hang a new IVPB, instead of priming the new tubing with the new medication, you connect it and allow fluid from the primary IV line to flow backwards up into the old, now empty IVPB bag line, flushing out the residual old medication.
Okay, so it clears the secondary line using the primary fluid.
Exactly. But there's a big caution here. You cannot use back priming if the primary infusion contains certain critical drugs.
Which ones?
Things like heparin, vasopressors, aminophylline, or even multivitamins. Pushing those primary fluids backward could mess with their delivery rate or concentration.
So check compatibility and primary fluid contents before back priming.
Got it. What about IV push or bolus meds? This is usually done only by registered nurses, depending on facility policy. It means pushing the drug directly into the vein from a syringe.
Does speed matter?
Immensely. Most 5e push meds need to be given slowly, timed over usually 1 to 5 minutes, to prevent adverse reactions. Read the drug monograph.
Are there exceptions? Really fast pushes?
Yes, some emergency drugs like adenosine are pushed as fast as possible, like in 2 to 3 seconds, but that's very specific.
There are drugs you never pushed IV?
Absolutely. Some drugs are incredibly dangerous if given IV push. The text mentions dopamine, potassium chloride, KCl, and vancomycin as examples. KCl especially can cause fatal cardiac arrest if pushed.
So always check the administration guidelines. We have tools to help, right? Like smart pumps.
Yes, smart pumps are a huge safety feature. They have drug libraries with preset dosing limits and infusion rates, and they'll warn you if you try to program something potentially unsafe.
Okay, one more critical safety point you mentioned earlier, insulin pens.
Yes, this needs reinforcement because mistakes have happened. Insulin pens are strictly, absolutely, for single patient use only. Period.
Even if you change the needle for each use.
Even with a new needle. Studies have shown that microscopic amounts of blood can actually be pulled back into the insulin cartridge after an injection. Sharing a pen, even with fresh needles, carries a documented risk of transmitting blood-borne pathogens.
That's a sobering thought. One pen, one patient, no exceptions.
No exceptions. It's a fundamental safety rule.
All right, let's finish up with topical and mucosal rights, starting with eyes, ocular medications.
Okay, for eye drops. First, if needed, gently cleanse the eye from the inner corner, the inner canthus, outward.
Prevents dragging debris towards the tear duct.
Exactly. Then, have the patient look up, gently pull down the lower eyelid to create a little pocket, the conjunctival sac. The drops go into that sac.
Not directly onto the eyeball, the cornea.
No, never directly onto the cornea. That can be uncomfortable and cause blinking, losing the medication after the drop is in.
There's a specific technique, right? To prevent systemic absorption.
Yes. Apply gentle pressure with a clean finger or tissue to the nasolacrimal duct, that little spot at the inner corner of the eye near the nose, for about 30 to 60 seconds.
And that blocks the drug from draining into the nose and throat and getting absorbed systemically.
Correct. It keeps more of the drug working locally in the eye where it's needed, and if you have multiple different eye drops ordered, wait a few minutes between them.
What about infants? They tend to squeeze their eyes shut tight.
Good point. For infants, you can place the drop right at the inner corner of the eye, near the nose. When the baby eventually opens their eye, the medication will flow into the conjunctival sac.
Clever workaround. Okay, how about ears? Otic medications.
Key thing for ear drops. If they've been refrigerated, you must warm them up first. Gently, like holding the bottle in your hand for a few minutes, or letting it sit out for about 30 minutes.
Why warm them?
Instilling cold drops directly into the ear canal can cause vertigo, dizziness, nausea, even pain. It's quite unpleasant.
Good to know. And how do you straighten the ear canal? It's different for adults and kids, right?
It is. For adults and children older than 3 years, you gently pull the outer ear, the pinner, up and back.
Up and back for adults and older kids.
Right. But for infants and children younger than 3 years, you pull the pinna down and back. That aligns the canal properly for the drops to go in effectively.
Down and back for little ones.
I got
it. Moving on to the skin dermal medications.
it.
Creams, ointments, patches.
First rule for anything applied to the skin, remove any old medication first, cleanse the site if needed, and always rotate application sites.
Why rotate?
Prevents skin irritation, and for some drugs can help prevent tolerance developing at one spot.
Anything specific about nitroglycerin ointment?
Yes, you measure the prescribed dose carefully onto the special ruled paper that comes with it. Apply the paper to the skin, ointment side down, secure it with tape or a dressing. But the crucial part is, do not rub or massage the ointment into the skin.
Why not?
It's designed for slow, controlled absorption through the paper. Massaging it in would cause rapid, potentially excessive absorption.
Okay. And transdermal patches, like nicotine or fentanyl patches.
Similar principles. Always remove the old patch before applying the new one. Document the location of the new patch, and rotate sites,
What's the big danger with patches?
cutting them. You must instruct patients never to cut a transdermal patch. It destroys the slow release mechanism, and the entire dose can be released at once, leading to a serious, potentially fatal overdose.
That's critical information. Don't cut patches.
Also, ensure the patch itself is applied, not just the adhesive overlay if it comes with one. Make sure the medication part is securely on the skin.
Right. Okay, last route. Inhaled medications. Inhalers and nebulizers.
If a patient is prescribed both a bronchodilator like albuterol and a corticosteroid inhaler like fluticasone, there's a specific order.
Which one comes first?
The bronchodilator always comes first. You use the bronchodilator to open up the airways, then you wait about 2 to 5 minutes, and then use the corticosteroid. The open airways allow the steroid medication to penetrate deeper into the lungs where it's needed.
Makes perfect sense. Open the doors, then send in the treatment.
Exactly. And after using a corticosteroid inhaler, what must the patient do?
Rinse their mouth out with water, right?
Uh-huh.
And spit it out.
Yes, to prevent oral thrush, a fungal infection that can develop from the steroid residue left in the mouth.
What are common mistakes people make with inhalers that reduce effectiveness?
Oh, several. Not coordinating the puff with their breath correctly, not holding their breath long enough after inhaling, ideally 10 seconds.
How do you know if the inhaler is empty? Shaking it.
Shaking is unreliable. Most modern inhalers have built-in dose counters. That's the only accurate way to know how many doses are left. Rely on the counter.
Good point. And nebulizers. Any specific monitoring?
Especially if using beta-adrenergic drugs via nebulizer, monitor the patient's heart rate, as these can cause tachycardia. Also, occasionally tap the nebulizer cup during treatment
Why tap it?
to make sure all the liquid medication gets aerosolized and isn't just clinging to the sides. Ensure they breathe it all in.
And cleaning nebulizers at home.
The text mentions a typical routine: daily rinse with water, and a weekly soak in a solution of usually 1 part white vinegar to 4 parts water, followed by a thorough rinse and air dry. Wow, we covered a lot of ground there. From the big picture, 9 writes, down to the nitty-gritty of Z-track injections and back priming.
We really did. It highlights how every single step, every technique is rooted in safety and ensuring the medication actually works as intended.
It truly does. These aren't just arbitrary rules, they're safeguards. Understanding the why behind things like not crushing an SR tab or pulling the pinna correctly is what separates routine task performance from safe, knowledgeable practice.
It transforms prescription into therapy safely. So as we wrap up this deep dive, here's something to think about, building on that safety focus. We know medication administration is one of the most frequent things we do, and it carries inherent risks.
High risk, high frequency, definitely.
So the question for you is, what's one step in the medication process? Maybe something you do almost automatically now, perhaps related to checking an ID, preparing an injection, or even documenting that you'll look at with fresh eyes after this discussion. What routine action will you now scrutinize a bit more closely, really thinking about the specific reason and the potential consequence behind that rule?
That's a great point for reflection, making the connection between the rule and the risk it prevents.
Exactly. Thank you so much for joining us for this essential deep dive into medication administration safety.
Our pleasure. Stay safe out there.
We'll talk to you next time on The Deep Dive.